بسم الله الرحمن الرحيم. أعزائي طلبة المرحلة الخامسة، نكمل المحاضرة الخامسة، وتوقفنا in previous lecture in the management and treatment of acute renal failure. Bladder catheter should be placed especially in case of there is obstruction or non-ambulatory patient to ensure adequate urine output. Determination of the volume status, very important. Make a chart for input and output evaluation of the volume status initially for a patient with acute renal failure. In case of hypovolemia, here will especially this pre-renal cause of renal failure, intravascular volume should be expanded by intravenous administration of isotonic saline 20 ml per kg over 30 minutes, and sometime in less than 30 minutes. We can repeat it 1, 2, or maybe 3 times. After volume resuscitation, hypovolemic patient must be generally void within 2 hours. Failure of void will be here make a challenge. We give this patient a challenge, diuretic challenge, and also put in mind presence of intrinsic or post-renal cause of acute renal failure. So after volume replacement, and if the child not void, we give a challenge, diuretic challenge, give diazepam 2 to 4 milligram per kg, or bumetanide as an alternative in 0.1 milligram per kg. If there is no response to the diuretic challenge, so the diuretic will be discontinued. We will go to the fluid restriction, and we give about 400 ml per meter square by 24 hours. This is an insensible water loss plus the amount of urine output. Now so we go from fluid replacement. If not void after this fluid replacement and diuretic challenge, we'll go to the restriction of the fluid. The type of fluid, mostly glucose, contain 10 to 30%. Mostly it is a 10% without electrolyte as maintenance of fluid, and also this fluid is modified according to the electrolyte balance. Fluid intake, urine, stool output, body weight, serum chemistry must be monitored and put in the chart. For the most important and serious complications, hyperkalemia. Hyperkalemia, as you know, the serum potassium is 3.5 to 5.1, and once we monitor the potassium, whenever the potassium is more than 6 milliequivalent per liter, there will be ECG change there. The first sign is a peak T wave, and then followed by widening of QRS, ST segment depression, and sometimes go to the ventricular arrhythmia or cardiac arrest if not treated. So as first and early part of management of hyperkalemia, exogenous source of potassium should be eliminated. We give sodium polystyrene sulfate, mean resin, mean chiaxalate. This exchange the sodium for potassium, and this is given 1 gram per kg, and the effect may take several hours. You know, the sodium is the most cation extracellular, while the potassium intracellular. So this is shifting the potassium between potassium and sodium is one of the action of the resin. If the serum potassium more than 7 milliequivalent, so an emergency, ECG change will be happen, and we give these measures. We give calcium gluconate 10% solution in 1 ml per kg IV over 5 to 10 minutes. We give sodium bicarbonate 1 to 2 milliequivalent per kg IV over 5 to 10 minutes, and we give insulin 0.1 unit per kg with the glucose 50% solution 1 ml per kg over 1 hour. All these tools to decrease the serum potassium to the safer level. For metabolic acidosis, primarily mild acidosis, it is a result of retention of hydrogen ion, phosphate, sulfate, but rarely requires treatment. If acidosis pH less than 7.5 and serum bicarbonate less than 8 milliequivalent, so corrected by IV sodium bicarbonate to raise the arterial to more than 7.2. For the hypocalcemia, patient should follow low phosphorus diet. Phosphate binder should be given by mouth to bind the ingested phosphate. and increase the gastrointestinal phosphate excretion. We give this phosphate binder with calcium carbonate. Start dose 1 to 3 tablets with a meal. For hyponatremia, the common cause of hyponatremia is a delusional disorder, must be corrected with a fluid restriction rather than giving the sodium chloride. And this given only just for symptomatic hyponatremia. There is seizures, lethargy, and sometimes we reach to the serum sodium less than 120. For gastrointestinal symptoms, which is nausea, vomiting, anorexia, GI bleeding, all which is a complication of acute renal failure. So we give IV H2 blocker such as ranitidine to prevent this complication. Hypertension and blood pressure monitoring is very important. Results, especially from primary disease of the process, like glomerulonephritis of HUS. So salt and water restriction is critical. Diuretic administration may be useful, or use nifedipine in dose 0.25 to 5 for lowering the blood pressure. Other drugs we can use like amlodipine or beta blocker can be used in management of hypertension. For neurological symptoms of acute renal failure include headache, seizures, lethargy, confusion. A potential etiologic factor who include hyponatremia, hypocalcemia, cerebral hemorrhage or cerebral vasculitis, or uremic state. All these may cause the neurological symptoms in acute renal failure. So diazepam is also effective in the controlling of the seizures. Correction of anemia if hemoglobin less than 7 grams per deciliter. Very important about nutritional side is critical important. Sodium, potassium, phosphorus should be restricted. Protein intake, which is the source of the urea, should be restricted moderately while maximize calorie to minimize the accumulation of nitrogenous waste product. When we send to the dialysis, it is indicated in the following. If there is a volume overload with evidence of hypertension or pulmonary edema refractory to the diuretic therapy, if there is persistent hyperkalemia instead of all measurement, severe metabolic acidosis unresponsive to medical management, neurological symptoms, altered mental status, and seizures, or there is blood urine nitrogen greater than 150 mg or lower if rapidly rising, there is calcium phosphorus imbalance with hypocalcemic tetany. These are all indications of the dialysis. For the dialysis, we have 3 types. Firstly, intermittent hemodialysis, useful in patients with relatively stable hemodynamic status. It can be done with 3-7 times per week. Peritoneal dialysis, which is we use in the pediatric mostly because it's an emergency and easy to access. We use hyperosmolar disalate is infused into the peritoneal cavity via the percutaneous base catheter. So there will dueling of this fluid for 45 to 60 minutes and then will be drained by gravity. This cycle can be repeated for 8 to 24 hours per day according to the patient's fluid and electrolyte. It's also contraindicated if there is an abdominal disorder. The third type of dialysis is called continuous renal replacement therapy. This is useful in the unstable hemodynamic patient, concomitant sepsis, multi-organ failure, or if there is intensive care unit. Use extracorporeal therapy in which fluid, electrolytes, small and medium-sized solute are continuously moved from the blood within 24 hours per day. What about the prognosis of acute renal failure? Depends on the nature of underlying disease, very important, rather than the renal failure itself. In general, children with acute renal failure caused by renal limited condition like post-infectious has a very low mortality, less than 1%. With acute renal failure related to the multi-organ failure, it's high mortality, related to the 90%. We'll talk now about chronic renal failure. Is defined as either kidney damage or decreased kidney glomerular filtration rate less than 60 ml per minute per 1.73 meter square for 3 or more months. This is a chronic renal failure. What about the etiology? Causes may be congenital, acquired, inherited, or metabolic renal disease. So children younger than 5 years is most commonly as a result of congenital abnormalities such as renal hypoplasia, or dysplasia, or obstructive uropathy. 5 years and above, mostly acquired glomerulonephritis, Albert, or maybe it's related to the metabolic disorder like cystinosis, hyperoxaluria, polycystic disease of kidney. How you classify chronic renal failure? According to the GFR. Mild renal failure meaning GFR between 50 to 75 ml per minute per 1.73 meter square. Moderate renal failure with a GFR between 25 to 50, and chronic renal failure if the GFR between 10 to 25 ml, and end stage renal failure if the GFR less than 10 ml per minute per 1.73 meter square. About the pathogenesis, here the renal injury may progress despite removal of the original cell. If you compare chronic with acute, acute can be the primary cause. Here, the renal injury will be progress. The nephrons are lost, remain nephron undergo structural functional hypertrophy, increase glomerular blood flow, but this with time cause a progressive damage and survival of the glomeruli. So this direct effect of the elevated hydrostatic pressure on the integrity of the capillary, as well as toxic effect of protein across the capillary wall. Other precipitating factor for further nephron damage were proteinuria, uncontrolled hypertension, hyperphosphatemia, and hyperlipidemia. Clinical manifestation: this accumulation of nitrogenous waste product, acidosis, sodium retention, sodium wasting, urinary concentration defect, and hyperkalemia. There will be renal osteodystrophy, which is hyperphosphatemia, hypocalcemia, secondary hyperparathyroidism. There will be growth retardation due to inadequate calorie intake, renal osteodystrophy, metabolic acidosis, anemia, and growth hormone deficiency. Anemia due to erythropoietin production decrease. There is iron or folate and B12 deficiency, decreased erythrocyte survival, bleeding due to the defective platelet function. Neurological, fatigue, poor concentration, headache, drowsiness, GIT may be bleeding or abdominal pain, hypertension, hyperlipidemia, pericarditis, cardiomyopathy, and glucose intolerance. The medical care for patient chronic should focus on the following: delay or halting the progression of chronic kidney disease, treatment of underlying condition if possible. It requires close monitoring of patient clinical and lab, hemoglobin, electrolyte, blood nitrogen, calcium, phosphorus, and there is periodic measurement of parathyroid hormone, X-ray, and echo also, ventricular for if you see if there is left ventricular hypertrophy and cardiac dysfunction. The very important fluid and electrolyte balance. Children with acute chronic renal failure, especially for renal dysplasia, will see a polyuric phase with significant sodium loss. He will give a sodium supplement, while children with high blood pressure, edema, and heart failure require sodium restriction. So we must know the cause and the electrolyte level and manage accordingly. Fluid restriction is rarely necessary in children with chronic renal until development of end-stage renal failure. Hyperkalemia need to be restriction of the potassium and supplement of kyaxylate. Acidosis treated by giving either bicitra, 1 ml equivalent of sodium citrate, or sodium bicarbonate tablet to maintain the serum bicarbonate more than 22 ml equivalent. Fluid restriction is rarely necessary in children with, as we say, in the chronic. Sorry for that. About nutrition, dietary phosphorus, potassium, sodium should be restricted according to the individual lab. Protein intake should be 2.5 gram per kg per day and should be consist with high biological value, multiplied primarily by amino acid rather than nitrogenous waste product. In high biological value, within protein, egg, milk, followed by meat, fish, and fowl. Supplement given for water-soluble vitamins, very important, zinc and iron. Watching of the growth in these children is very important. Most of the children less than 2 standard deviation of the height, in spite of abdominal care. So this use recombinant of growth hormone, and maybe continue until the patient reaches 50 percentile for mid-parental height. For renal osteodystrophy, so this is one of the spectrum of bone disorder seen in chronic renal failure. So there will be decrease in the functional renal mass due to the decline in the 1-alpha hydroxylase activity and decrease in production of 1,25-hydroxycholecalciferol. This will lead decrease in the intestinal calcium absorption, hypocalcemia. There will be an increase in the parathyroid gland activity, excessive parathyroid secretion, lead with the bone resorption. This a circle of chronic renal failure compensatory mechanism, enhanced phosphate excretion, become inadequate, result in hyperphosphatemia. This will lead to the hypocalcemia and increased parathyroid secretion. So this patient presents with muscle weakness, bone pain, fracture maybe, and maybe there is arithritic, especially in the growing change, and bone change like varus and valgus deformity. X-ray of raised bone see subperiosteal resorption and widening of the metaphysis. Treatment with low phosphate diet, with phosphate chelation like calcium carbonate, plus vitamin D supplement. Anemia, as we say, due to either deficiency of iron, folate, B12, as well as the erythropoietin. So we give a recombinant erythropoietin administration if there is hemoglobin less than 10 gram per deciliter at dose of 50 to 150 milligram per kg per dose subcutaneously 3 times per week, and should be received iron supplement with that. Hypertension AC inhibitor, enalapril, lisinopril, also effective as anti-hypertensive medication, especially for proteinuric renal disease. Immunized should be immunized, all standard immunization except for receiving immunosuppressive medication. Adjustment of the very important drug dosage according to the GFR. And uremic manifestation should be treated with a chronic renal replacement therapy. We talked previously about that one, about hemodialysis, peritoneal dialysis, or renal transplant. Indication for that, if there is severe metabolic acidosis, hyperkalemia, presence of pericarditis, encephalopathy, intractable volume load, failure to thrive, there is peripheral neuropathy or intractable intestinal symptom, or GFR less than 10 ml per minute. Thank you very much.